Hello everybody. Today we are discuss about percutaneous tracheostomy. Tracheostomy is the common surgical procedure performed on the critically ill intensive care patient. Minimally invasive procedures are rapidly transforming many areas of surgical practice. Percutaneous tracheostomy is the minimal invasive alternative to the conventional tracheostomy. Two new methods suited for the elective percutaneous tracheostomy at bedside have been introduced based on the Seldinger technique. The Siagilia method developed by the Siagilia uses the graded dilator and is currently most popular method. Another technique described by Greeks et al. At 1990, it is a one-stage dilation technique using modified Howard Kelly forceps as the tracheal dilator. So indication for tracheostomy to facilitate weaning from the positive pressure ventilation and sedation, bypass and obstruction of the upper respiratory tract, prevent aspiration from pharynx or GI tract, facilitate removal of secretion by aspiration, facilitate long-term airway management. Condition in which surgical tracheostomy may be safer than the percutaneous tracheostomy is emergency tracheostomy, tube placement, difficult to palpate anatomical landmarks like very obese patient, short or bull neck, enlarged thyroid, non-palpable cricoid cartilage, gross deviation of trachea. Infection at or near infected site for tracheostomy. In pediatric age group, children have more compliant trachea than the adult, leading to the tendency to collapse when pressure is exerted with the diet. Previous neck surgery may distort the anatomy. In unstable cervical spine fracture, required PEEP of more than 15 as oxygenation may be compromised during the procedure. Malignancy at the site of tracheostomy. Uncontrolled coagulopathy considered as a relative complication. Now, the advantage of percutaneous tracheostomy over surgical tracheostomy. It is relatively simple technique suitable for trained staff in the critical care setting. It does not require operating theater and the procedure is usually performed under local anesthetic. Sedation and the neuromuscular blockage are appropriate. Form a stoma between the tracheal ring, resulting in reduced blood loss as there is usually no disruption of the blood vessel. Moreover, the tracheostomy tube is fitted snugly in the stoma, thereby minimizing any tendency to bleeding after the procedure. Infection rate after percutaneous tracheostomy ranges from 0 to 3.3%, whereas those for the open tracheostomy have been reported to be as high as 36%. Stenosis rate for the percutaneous tracheostomy ranges from 0 to 9%. The reported incidence of late complication resulting from the open tracheostomy, such as tracheal stenosis, tracheomalacia, fistula, and scarring, varies widely. Small and neat stoma of dilated tracheostomy generally results in more cosmetic scar. Now, description of technique. The primary requirement of the performing percutaneous tracheostomy is presence of trained anesthetist for managing the airway of the patient. They should be equipped with the drug and the instrument for the rapid sequence orotracheal intubation with the cuff tracheal tube. The patient should be adequately anesthetized to avoid the movement and should be monitored during standard ticking. The neck is extended by placing stand bag under the shoulder and the area around the indented tracheostomy site is clean with the antiseptic solution. The area is surrounded by the autoclave drips. The thyroid cartilage, cricoid cartilage ring are identified by palpation. The desired space for tracheostomy is identified, which may be between first and second or second or third ring. Cuff of the existing tracheal tube is deflated and the tube is withdrawn under direct laryngoscopy until visualization of its cuff in the larynx. The tracheal tube must be carefully stabilized at this time to prevent the dislodgement and the cuff reinflating. Withdrawal is necessary to allow the unimpeded passage of the guide wire and dilator into trachea. The use of fiber optic bronchoscopy reduces the risk of complication associated with percutaneous tracheostomy. It may be positioned in the endotracheal tube to observe or check that the point of entry of the needle is through the center of the anterior tracheal wall. Care must be taken not to damage the bronchoscope with the needle. Fiber optic bronchoscopy also allows the observation of the passage of dilator or entry of modified Howard Kelly forceps, reducing the risk of damage to the posterior tracheal wall during the procedure and confirming the correct placement of the tracheostomy tube. The patient should be pre-oxygenated by ventilation with 100% oxygen for at least 5 minutes before starting procedure. The orotracheal tube should be kept in situ until ventilation can be transferred to tracheostomy tube, which should be confirmed by auscultation of the lung and ideally by capnography. Laryngeal mask airway may be used in the place of orotracheal intubation prior to tracheostomy in certain ICU patients, for example, those requiring relatively low insufflation pressure to maintain adequate gas exchange without the risk of aspiration of gastric content. Infiltration of the soft tissues of intended site for the tracheostomy with local anesthetic is recommended to reduce the bleeding. A horizontal incision is made at the anticipated point of entry with scalpel bit. The blunt dissection with forceps is carried out, which allows the palpation of cricoid and upper tracheal ring. The needle and cannula assembly are now carefully introduced in the midline, either between the first and the second or between second and third tracheal ring. So this is the figure 1 which demonstrated the introduction of the needle between the first, second and third tracheal ring. The needle is then slowly advanced with the continuous aspiration until the position of the needle tip in the trachea is confirmed by aspiration of the air. A J-tip flexible guide wire is threaded through the cannula into the trachea and the position is checked using the fiber optic bronchoscope. Next is small and the firm introducing dilator. It slide over the wire through the soft tissues into the trachea. The dilator is then removed and ensuring that wire stays in the place. So this is the diagram which showed the introduction of the dilator. In the dilator or the C. Aguilar technique, the stoma is then dilated using series of curved taper dilator starting with the smallest dilator. The dilator is slide over the guiding catheter until the blunt end of the dilator aligns with the dilator positioning mark on the catheter. During dilation, the tip of each dilator is lubricated with the sterile aqueous jelly and pushed in and out several times with the firm pressure. The twisting action or the moving the dilator to and from in the trachea may aid the dilation. The trachea is dilated gradually up to size above the dilator which feeds the tracheostomy tube. Now the tracheostomy tube is slide over the snugly fit or lubricated dilator. The tracheostomy tube is also lubricated and both are then introduced into the trachea. Finally, dilator, guide wire and guiding catheter are removed, leaving the tracheostomy tube in clear place. In the blue rhino dilator technique, the serial dilators are replaced by single graduated dilator. So this is the diagram of showing the dilator tube. In the Giggs technique, after the wire is in place, the dilator is removed and the free movement of the wire is checked. The dilating forceps are advanced with the same tip at the angle of approach to the trachea as the wire to the fashion in the stone. The handle of the forceps is lifted with the vertical position and the open to tear the trachea between the ring. The blades of the forceps should lie in the trachea and parallel to it. The forceps are now withdrawn in the open position and ensuring that the stoma is large enough to admit the tracheostomy tube. The tracheostomy is slide with its obturator in place down over the wire into trachea. The guide wire and the obturator are then removed, leaving the tracheostomy tube in place. The cuff of the tube is inflated and the ventilator breathing circuit is connected, and the tube is secured by tapes around the neck. Satisfactory ventilation is verified by auscultation of the chest. The tube is then aspirated to remove the blood and secretion. Presence of surgical emphysema at the site is also watched for, and the chest X-ray is performed to check for a tube position and the pneumothorax. A fiber optic bronchoscope is the inserted wire tracheostomy tube into trachea. Satisfactory position can be confirmed. Now about complication. Although complications are similar to the surgical tracheostomy, the incidence is low. One study cites the overall mortality rate with percutaneous tracheostomy to be 0.3% as compared to 3.2% for surgical tracheostomy. The incidence of tracheal stenosis was 3.3%. In surgical tracheostomy, it is 6.6%. The overall complication rate was about 15%. In surgical tracheostomy, 42%. About early complication, during the procedure, the patient may develop hypoxia due to failure and of ventilation. Furthermore, the ventilation of the patient may also be difficult if the cuff of the tracheostomy tube is inadvertently punctured. If any difficulties are encountered on insertion of tracheostomy tube, the existing endotracheal tube should be advanced beyond the incision in the trachea and ventilation recommence until the patient is stable enough to resume the procedure. The patient may develop pneumothorax, pneumomediastinum, or creation of false passage and subcutaneous emphysema due to placement of tracheostomy tube in the paratracheal space. Damage or injury to the posterior tracheal wall may lead to the tracheoesophageal fissure. Major bleeding is unusual and minor bleeding can usually be controlled by pressure and occasionally a suture. Hemorrhage into airway is potentially dangerous as it may result in blood clot obstructing the airway. Needle puncture of lateral wall of trachea may subsequently lead to the stenosis. Dislodgement of tracheostomy tube soon after procedure may be hazardous as the entry into the trachea is small and deep, hence the replacement of the tube may be impossible. The percutaneous tracheostomy tube should not be pushed blindly back, but replaced after proper dilatation of tract following orotracheal reintubation. Secondary hemorrhage may occur either from infection or erosion of vessel. Now about late complication, the incidence of clinically significant subglottic stenosis is low in percutaneous tracheostomy. The reason behind development of subglottic stenosis include laryngeal edema, damage to the tracheal mucosa, high pressure exerted by endotracheal cuff, and prolonged translaryngeal intubation. However, in some series, the incidence of subglottic stenosis in percutaneous tracheostomy is lower than in the open surgical tracheostomy group. Thank you, guys.